Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan. Now, here is your host, Joe Steckler.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is low vision. Joining me is Dr. Eric Straut, optometrist with the Eye Institute. Welcome, Dr. Straut.
Thank you, Joe.
It's before we began the show, I said that in doing all the television shows I've been doing over these years, I've never had really an optometrist on the show. And you very quickly let me know that the field of optometry has changed from what I probably conceived it back in the 60s and 70s.
You know, that's very true, Joe. And I appreciate being here and happy to represent optometrists out there. You know, certainly our education has advanced a lot. You know, originally it was more focused just on providing glasses prescriptions for patients. And now we're much more into the medicine, much more into the medical eye care.
I don't think, Dr. Straut, I don't think people understand or have really given much consideration to the different disciplines of medicine involved in care and treatment of the eyes. I think for many years it's sort of been an under-talked about medical topic.
You know, I agree, Joe. A lot of patients feel they just need to have one eye doctor. You know, a lot of patients have a primary care physician, and perhaps they see an endocrinologist or a cardiologist or a dermatologist as well. That's how we need to think about eye care. You know, perhaps you do have your family eye physician, but sometimes you need a specialist with more advanced care. For me, my specialty is low vision. I really work with patients to help improve the quality of their vision and really try to help them do those things that they want to do and need to do. When
you say low vision, this is one of the first time in all the television shows that I've done that I did not go to the internet and do a lot of study. I have a fairly decent background because I have my own eye problems, so I've done some research in that area. But would you just describe for our viewing audience, what do you mean by low vision?
Absolutely. So low vision from a medical perspective is reduced vision, reduced functional vision really, due to an eye disease or problem. Now this can be one named disease, you know, one more serious condition, perhaps like age-related macular degeneration. But in some instances, it's just a combination of more mild conditions or age-related changes. You know, from my perspective, it's really much more simple. It's more functional. If a person can't see to do the things they either want to do or need to do, I would consider them to have low vision.
Years ago, and I'm talking many years ago, I attended a function at the Naval Academy, and my wife and I lived in Falls Church, Virginia at the time. So we had to go use the Beltway to go around to get to our house over in Virginia, or cut straight through Washington. And it was roughly 2 o'clock in the morning, so we decided to go through Washington, D.C. And the way the lights were, and the street lights thing, I really couldn't read the street signs. So, and we had a little fog too. And I would pull the car up, turn the lights on bright, and read the sign. I had done that several times, and all of a sudden this police car pulled up behind me.
Uh-oh.
Yeah, and I got out of the car, and the policeman asked me, why was I doing that? I said, well, I can't read the sign. And that's the way the lighting is. So he looked at me and he said, what submarine were you on? I said, how in the world does he know that? I had my belt buckle on with the dolphins on it. So the next thing he said, I told him where we were trying to go, he says, follow me. So he does almost a wheelie in the street, and he and his partner tear off through the streets of D.C., and my wife and I are following him to get to the other side. But you know, when you have an eye problem, and this seems like it opens up so many people to helping you.
That's very true.
But when you made, I was wondering what was the eye disease that you would compare low vision to when you picked macular degeneration. It seems that macular degeneration is becoming more of a household topic today than it was years ago.
That's very true. It's more Joe, really. We know more about macular degeneration these days. We can catch it earlier and earlier. At the Eye Institute, at my office, we have some advanced technology to detect it very early. We have these digital scans that look at the retina, electrodes that essentially map the function of the retina, and we can catch things extremely early. There's not a whole lot of treatment for early macular degeneration, but monitoring it is extremely important. We talk about the dry and the wet forms of macular degeneration. If we're not familiar with that, the dry form, Joe, it's really just those normal aging changes. And as things progress, we can get into this wet form. And the word wet really comes from leakage, essentially. You get blood or fluid in the eye, and that can cause vision loss quickly. The only really way to determine if we have that is through a comprehensive exam where we dilate your pupils.
But this is one of the advantages. I talked to Dr. Palmer, who is a corneal expert for our specialist from the Eye Institute, and we got on the subject of the exact thing that you're talking about, having disciplines together under one roof that can help treat something. It's just like one senior place is a place here in Melbourne where they've tried to house all these disciplines together that address aging issues. You've done that at the Eye Institute. There are several places like that, but I'm very familiar with what the Eye Institute does. And I see the immediate advantage to having experts next door to each other.
That's absolutely correct. We can take excellent care of our patients because we have experts, as you mentioned, in every discipline. A patient can come in just for a normal eye exam and perhaps not know that they have something going on, or they feel that they just don't see as well as they should, but they're not sure why. With having all of these experts, we can send a patient to where they need to go and help them in whatever way we can. It's really nice to work as a team to provide the best care possible.
As an optometrist now, let's talk about your specialty. Sure. If a person comes in thinking they need glasses, they don't see as well, they don't read as well. And just like me, for my book, I use size 18 print on my paper so that I can see it easily. Reading newsprint is very difficult for me.
Absolutely.
And when they lighten the ink on the small print, it makes it even more difficult to read.
That's correct.
But if a person comes in to you as an optometrist with the advances that you've made in optometry, what do you do if they came in and said, I think I need glasses? What do you do as an optometrist now with the new technology?
That's a great question. And with low vision as my specialty, we can really go beyond those traditional techniques for the finding of glasses. And that's how low vision is often initially detected. Patients go to their family eye physician and they say, I think I need glasses. And often it goes beyond that. Patients are diagnosed with various eye diseases or problems that traditional eyeglasses just simply can't overcome. Or when we're trying to find eyeglasses, and we have these traditional techniques. We've all been through the whole better one, better two type of routine with our family eye physician. And that can be confusing, and it can become overwhelming for some patients, particularly with patients with reduced vision. And if that happens, a patient can end up with a prescription that just doesn't have them reaching their full potential. So I use a few more advanced techniques. I have a technique called retinoscopy. And essentially what that does is I can objectively, without your input and without asking all of those confusing questions, I can determine your prescription. And this is a very good opportunity for me to provide the best prescription possible. Now that said, once we try traditional eyeglasses, if that fails, we turn to low vision devices. And these things range from handheld magnifiers of various types to these technologically advanced digital magnifying devices, such as a closed circuit television.
Okay.
And there's just a lot of different options out there, and it's really tailored to each individual.
Okay, hold right there a minute. I wear glasses.
Sure.
I have cataracts.
Sure.
But I sense that low vision is much more than just poor vision.
That's correct.
So what is the real difference between low vision and poor vision?
You know, vision is extremely subjective, Joe. We get patients in the door and they're reading quite poorly on our eye chart, but because of their activities of daily living and because of the way they live their life, they perceive their vision to be very well, very good. So for that patient, I would say subjectively that they may have poor vision, but for their lifestyle, they wouldn't be considered to have low vision because they can do all the things that they want to do and need to do. When a patient starts having basically difficulties in the home, you know, they can't see to read their pill bottles, to take their medication accurately, perhaps they can't see to view photos of their grandchildren or the television, or to do whatever hobby or task they have in mind, that patient would then be considered to have low vision.
You know, I wish that audiologists would approach the ears like maybe you've approached the eyes over the years.
Certainly a functional in nature, absolutely. Yeah. I agree.
But when you talk about poor vision, and you talk about devices to help people see, I can remember seeing people wear very thick lenses in their glasses, or it seemed like you reach a point where you can't make the prescription magnify the print to where you can read it.
Absolutely. And that's sometimes when patients are first diagnosed as having low vision. You know, say you see your family eye physician and they say, you know what, Joe, just this time we can't make your vision any better with glasses. So then the question is, what do we do now? And that's when patients come to me as a low vision specialist. And we go beyond the eyeglasses and search with these magnifiers and other low vision devices that I mentioned earlier.
If a person like me, and I learned from Dr. Palmer that almost everybody has cataracts. That's something that
absolutely
I didn't know that.
Absolutely.
My wife said she was amazed to hear that too, that
yes.
We all had cataracts. But if you reach a point where you sort of get in a holding pattern, you don't want to have, you're afraid to have cataracts removed, or you have something that says you can't remove the cataracts. Does the field of low vision provide options where people could still function normally without having to have cataract surgery, or how do you advise people when you get into that mix and match situation? You
know, Joe, that's true to some degree. Cataracts cause a number of problems, only one of which is just blurry vision. It can cause problems with glare, you know, halos at night, trouble driving at night, and just a general discomfort in low light conditions. Those types of things generally cannot be overcome with just regular eyeglasses. Certainly with certain tints on the lenses, such as a yellow tint or a light gray tint, we can overcome some of the glare issues. And absolutely, a low vision device, especially for, say, reading, can overcome issues caused by cataracts. Ultimately, however, the best vision is typically had by having the cataract surgery, but certainly every case is different. And this is why a comprehensive exam with dilation of the pupils is so important.
Okay, let's narrow our discussion down. Let's say that a person has cataracts, has low vision, poor vision, and you have the cataract surgery and your vision is still impaired. What new techniques, what devices, what do you do as an optometrist to help those people see better? And can you help them see better?
In most cases, Joe, the answer to that question is yes, we can help them. You know, the visual system is extremely sensitive. The light essentially has to enter the eye through the clear tissue in the front of the eye called the cornea. So that tissue must remain clear. So let's say you have a scar on your cornea or damage to the front of the eye. That patient could have low vision. Therefore, if that patient had cataract surgery, those other problems, such as the corneal scar, would still cause difficulty. Another instance is the retina behind the eye. Even after cataract surgery, The cataract surgery does not fix any existing, say, macular degeneration or diabetic eye disease, for example. And then we must overcome those conditions. We use a few techniques with those types of patients. There are really, Joe, overall very few conditions that cause total loss of vision, and those conditions are very rare. Most of the time, these conditions have us simply losing areas of our vision. An example of this is macular degeneration. The macula is just the very center of the vision. If damage occurs due to macular degeneration, it often just causes a blurry spot right in the center of your vision, but that peripheral vision remains unchanged. So often patients can learn by turning their head or their eyes to use that peripheral vision to their advantage. There's a term for this called eccentric viewing, and essentially that just refers to that head turn or eye turn that lets us use those functional areas. We initiate training in the office, and we give a lot of handouts for loved ones and the individual at home to essentially practice this. A lot of patients can learn to quickly and accurately use those areas of vision, and it improves their function. And this is obviously at no cost to the patient. It's simply just through training. We can really kind of relearn to use our eyes.
You've mentioned a couple of key words which fall back, I think, in the area of diseases. What are some of the diseases, like in heart, we have stroke risk factors, we have heart attack risk factors, and we have lifestyle changes that we can implement to improve our chances of not getting a stroke or having a heart attack. What we can do in the same vein regarding our eyes? What are some of the diseases and risk factors we have that impact us in not doing everything we can to see better?
Sure, that's a great question. So the big two conditions that we see in the United States, at least, is age-related macular degeneration and diabetic eye disease. Those are the number one and number two causes of low vision and visual disruptions in the United States. So certainly as far as preventative medicine goes, we can take care of ourselves with regard to diabetes. If you're diagnosed with diabetes, we need to be following up with a primary care physician or endocrinologist, controlling our blood sugars, exercising regularly, and just general control through the diet. As far as macular degeneration goes, that really falls in the realm of us as eye physicians. We need to closely monitor for that wet form of macular degeneration, which I mentioned earlier.
Right.
In addition to those two things, there's really many other conditions that can affect the retina. Behind the retina is essentially the visual pathway. You see the light signals enter the eye, and then they really have to go all the way back to the back of the brain, where we basically do our image processing. All along that pathway, where the signal goes through the brain, it's very sensitive to things like strokes, like you mentioned. A patient who has had a stroke in the past, or perhaps just a series of mini strokes, can actually lose areas of their vision. This can cause low vision.
I suffered a stroke. I was, the good Lord was very kind to me. I retained my memory, my speaking ability. I was not disfigured or anything like that. But I did tell my wife that I believed that my vision, as poor as it was even a little worse.
Certainly.
And the same thing with my hearing. And of course, my family thinks I'm as hard of hearing as I can be. But these are things you have to deal with. You can cope with that easier than you can cope with not being able to see something. And when you talked about macular degeneration, at times when I look at something, I see like a spot in the middle where if I move my head, I can see around it to read. What is happening there?
So, without a full eye exam, it's difficult to pinpoint, but that certainly could be, from the sounds of it, due to early changes from macular degeneration. But again, Joe, I mentioned that full chain of events, basically, where the light enters the eye,
right,
hits the retina, and goes all the way back to the brain. It's essentially like a long chain, and a loose link or damage anywhere, Joe, can cause that chain to break and visual disruptions begin, essentially. So it's difficult to pinpoint exactly what's going on. Those same symptoms could be caused, for example, by a scar in the very center of the cornea, the tissue in the front of the eye. It could cause those same symptoms. That's why a full eye exam where we dilate the pupils and examine the peripheral retina is so important.
We wear glasses, and when we get glasses, we can get coatings put on the lenses to prevent scratching or maintain the surface smooth. And by doing all those things, it maintains our eyeglasses in a better condition so we can see through them.
Correct.
But not often do we ever talk about how we can scratch the surface of our eyes, which would impair our vision. And a good example of that would be dry eyes.
Correct.
We can do things to damage our eyes unknowingly.
Absolutely. And that's especially true with dry eyes. The way we see is essentially physics. The light must hit the eye. It must hit a nice smooth surface so that it bends into the eye and focuses on the back of the retina. For patients with dry eye, if you look at their eye under a microscope, it's essentially a roughened surface, almost like a desert, compared to a nice smooth lake for a patient without dry eye. Now, it's interesting, you mentioned with dry eyes, as we age, the front of the eye becomes less sensitive. So the eyes can be drying out, the vision can be becoming blurry without you really knowing why. Now, in some cases, the eyes do actually feel dry. You feel like maybe there's something in your eye or it feels a little gritty. But in some cases, we don't feel anything at all. And a patient might say, Doc, sometimes I see better than others. And if I blink some and really try to focus, things become clearer. They're surprised sometimes when I say, you know what, that's due to dry eyes. Another thing it can cause, and this sounds a bit like an oxymoron, is that the eyes can tear excessively, even running down the cheeks, secondary to dry eye. This is because this is the body reacting to that dry spot. The only thing it knows how to do is make these excessive tears that can run down the cheeks.
Is that good or bad?
Well, it's actually bad, Joe, because these tears are reactionary tears. They're not the good type of tears that keep our eye moist. So it's actually not a good thing. But sometimes patients look at me very interested when I say, your eyes are dry and they're having tears coming down their cheeks. They just don't understand why.
You wear glasses.
I do.
Why do you wear glasses?
So I wear glasses essentially because I just need a small prescription change. It's interesting, Joe, that I really only wear my glasses when I need my best vision. And this goes back to the subjectivity of vision. When it's the weekend, I take my glasses off because when I'm working around the house and doing things in the yard and the garage, I don't really need them. But when we're doing our eye exams on patients and I need my best vision, I do put my glasses on. And this goes to show you where patients may feel they see well, but when in fact they don't. Because on the weekends, I think I see great. But if you put me in the exam chair, perhaps not so much, and I need my glasses.
I have heard it said that if you wear glasses, your eyes become dependent on you using those glasses and needing the glasses. And if you don't wear the glasses, you can train your eyes to where they don't need the glasses. Is that a fact or myth?
That's actually a myth, Joe. And it relates to essentially the brain and the brain wanting to see clearly. So when you put your glasses on, your brain becomes essentially very happy, for lack of a better term. It gets used to that nice clear image. So when you take the glasses off, it perceives it as being much worse than it was before you put the glasses on. It's a very interesting, essentially, concept where a patient will come to me and say, I think these glasses are making my eyes worse. And then when you check them with the glasses, they see just fine. It's just the brain getting used to that nice, clear image.
As an optometrist and knowing all that you can do at the Eye Institute with all the disciplines you have there, what would you recommend as a course of eye care for senior citizens? What should we do?
That's a great question. And I know that people of that generation are very hardworking. They've often been through a lot, and they tend to let themselves suffer sometimes with vision problems. And they put it off. They say, I'll go next year or next month, and they don't let themselves see as well as they could. So my suggestion for everyone listening today is to have that comprehensive eye exam with dilation of the eyes. I can't say enough of how important it is for the dilation portion. You know, there's places where you can get a quick exam and it's not as thorough as it is at, say, the Eye Institute, where we have multiple disciplines and we can take care of you with essentially any specialty you may need.
What is the real purpose of the eye dilation? What does that really do? What does that help you see?
That's a great question. So the eye is essentially a complete sphere, Joe. And when you look at my eyes and your eyes, the colored part of the eye, which is the iris, it's essentially a muscle. And it blocks the view into essentially 2/3 of the eye. So when I look at your eyes without dilation, I can really only examine the first 1/3 of the tissues. I need to open up that muscle so I can look into the eye and examine the retina. This is especially important for things like I mentioned earlier, macular degeneration, diabetic eye diseases. You know, perhaps someone out there has been told you've had a stroke in the eye. That's only revealed through a dilated eye exam.
Wait a minute, say it again. Stroke in the eye?
Yes. So just like we can have a stroke, essentially a stroke is blood loss, temporary blood loss with damage to the tissue. That can actually occur in the eye. You know, the eye, Joe, it's an interesting place and it's a great field to be in. When we look into the eyes, it's the only place in the body where we can see arteries and veins in their natural state. And it's some of the most small and most sensitive vessels in the body. Therefore, conditions like diabetes, which really is a blood vessel disease, we can detect it so early. Now back to your question about the stroke in the eye, patients can lose blood flow to the eye itself, and essentially they'll quickly lose an area of the vision.
What can you do anything to alleviate that, or
we're
almost out of time? But try to answer that.
Absolutely. So sometimes if we lose blood flow to the eye, that can cause leakage, a buildup of fluid in the eye. If that occurs, that can cause more problems, and that certainly can be treated. Now, the vision loss from those conditions often cannot be restored. But with low vision, sometimes we can overcome this by adapting with things such as magnifiers or other low vision devices.
Okay, we're almost out of time, but I'm going to tell you what. I'm going to talk to the people who are at Eye Institute. I want to get you back for a follow-on show because I think you've opened up so many areas that we could talk about this more, because I think seniors need to know about it. But thank you, Doctor.
Certainly. And thank you, Joe.
I want to thank you, listeners, our viewers, for watching today's episode of Focus on Seniors. If you have questions or comments, please call us at 321-473-7770. And for more information on senior care and resources, visit our website at helpingseniorsofbrevard.com. Be sure to listen to Focus on Seniors on radio station 1300 AM WMEL every Thursday morning at 9 a.m. And also look for our Focus on Senior column in the Florida Today Health section of the Thursday newspaper. I'm Joe Steckler, and thank you for joining us today for Focus on Seniors.